Good morning, everyone. I am Brenda Dewberry, co-president of the Ohio Kinship Grandparent Coalition. I want to welcome you to the July 15th meeting. Please know that we're happy to have you on board. And today's presentation, we hope you will find very informative. I know as a caregiver, I've had personal experience with a child with fetal alcohol syndrome, and I'm looking forward to hearing Dr. Oregon's presentation. Please put your email information in the chat for a gift card. At the end of the meeting, we will pull a name to receive a gift card. On August the 19th, as a part of our agenda, I'm going to announce that we are going to have an Advocacy Day information meeting. This will be for caregivers and will serve as an opportunity for us to provide you with information that will be critical to the success of the legislation day on September the 9th. There will be no formal meeting in September. However, you will have the whole entire day in which to complete the directions we will provide for you on August the 19th. We hope that each and every one of you will have an opportunity to attend, as this is a very critical meeting as we try to reach our senators and state representatives to make them aware of our needs as caregivers. At this time, I'm going to introduce our guest speaker. Our guest speaker is Dr. Aragon. She is going to provide an informative session on the fetal alcohol spectrum disorder and the impact of prenatal alcohol exposure, red flags, and basic interventions. Dr. Aragon is a clinical faculty, a licensed clinical psychologist in the state of Ohio, and a former professor at the School of Professional Psychology at Rice State University. And of course, I'm not going to read the whole entire bio, but as you have received it prior to registration. But of course, if you have any questions afterwards, we welcome them. Please know that Dr. Aragon has conducted numerous fetal alcohol syndrome evaluations, sat in IEP meetings to advocate for children and families impacted by fetal alcohol, and has provided consultation to families. She has also provided several trainings to mental health agencies, trained staff at various organizations in the areas of identification, screening, diagnosis, treatment, and prevention of fetal alcohol syndrome disorders. Please welcome Dr. Aragon.
Hi, thank you everyone. Good morning, and thanks for being here today, this morning, to talk about and discuss together the impact of prenatal alcohol exposure on children. So I will quickly share my screen, and so let me play from start. Just wanted to make sure you can all see my slides. Do a thumbs up, right? Okay. All right. And you can all hear me well?
Yes.
All righty. Very good. Thank you. Okay. Today I'd like to introduce, and I know that a lot of you have been working in this area, so I'm kind of like going to do a summary for the fetal alcohol spectrum disorder. I'll talk about some of the red flags, and then I will do the second part is going to be on the basic interventions when we are working with our children clients, both as caregivers, as also mental health professionals as well. So, as we know, fetal alcohol spectrum disorders is the name FASD is not a diagnosis, but it is an umbrella term that kind of like has many diagnoses underneath that. So when we see FASD, then it has 4 different diagnoses underneath that, which later I will be talking about in more detail. But what we know right now is that it is the most common leading cause of cognitive impairment, developmental disabilities, and birth defects in the United States. So, as we know, alcohol is a teratogen, and if we compare it with cigarettes, alcohol, and drugs, then in terms of the severity of the impact before a baby is born, alcohol is in the top in terms of how harmful it is as a substance. So in that sense, what it means is that alcohol can pass through the placenta and the brain-blood barrier in the unborn baby's brain, and therefore impact the structures in the brain that are just developing before, of course, the baby is born, especially in the third trimester when the brain development at its highest and peak. And if there is alcohol exposure, it directly interferes with the neurons and with the development of the pathways in the brain, as a result of which some of the structures, when the baby is born, some of these brain structures get impacted very severely. And what does that mean? What does that mean that brain structures develop differently? It means that when they are born, some of the functions of these structures will be different than the neurotypical children. And this is what we're going to see in terms of behaviors, dysregulation, memory difficulties, learning difficulties, difficulties with daily living. So that's what it means afterwards, when they kind of like grow up, and then when they get to do school and their life and so forth, which we call functional impairment. So in that sense, so how we can summarize this is that alcohol is a harmful substance. And as a result of that, that's something that needs to be refrained totally during pregnancy. So the current prevalence of FASD with the latest research is around 1 to 5%. So what I'd like to say is that it is more prevalent than it's more prevalent than autism. And we hear about autism all the time. It's everywhere. People get, kids get diagnosed, kids get screened. The pediatricians, send the kids for referrals, for diagnosis, and so forth. However, we are not at the same level with FASD, just like autism or ADHD is, but at the same time, it is more prevalent than autism. So that's why we sometimes refer to it as the invisible disability, because not very many people know about it. Not very many people are aware or informed about it. And not very many women are also informed about the fact that alcohol is something that needs to be refrained during pregnancy. So it is really prevalent, and therefore it is a significant public health concern. So how does alcohol then impact all the things that I mentioned in the unborn baby's brain? So a child will be diagnosed with any of the diagnoses under the spectrum, the FASD, if only the mother has consumed alcohol during pregnancy. So if the mother has consumed alcohol before she was pregnant, that is not an issue. However, it only would lead to a child to have FASD if the mother consumes alcohol during pregnancy. However, what we know is that not all women who drink during pregnancy are impacted, and not all babies are impacted the same level. And you might ask why? Because alcohol is alcohol, right? Well, here is the reason for that. Let's think about one mother who gets prenatal care, who does not have, let's say, domestic violence, trauma, stress in her life. She gets a good nutrition. She has support during pregnancy, and she does not have prior mental health diagnoses like depression, bipolar, and so forth, right? So, and then let's think about another mother who is experiencing trauma and domestic violence, who is not getting regular prenatal care, who does not have good support in her life. Maybe she's a single mother, and maybe who has some prior mental health diagnosis, right? Like anxiety, depression, trauma, PTSD, and so forth, which a lot of women that we work with do have those. Then the second mother that I was talking about, if she drinks alcohol and then the first mother drinks alcohol, the second mother's child will be more severely impacted than the first mother that I talked about. Because all the other things like that I talked about, like good nutrition, support systems, and good mental health, and a lack of, stress, and a good prenatal care, those will be some protective factors. So that's one thing. So that's why not two women who drink the same alcohol will be impacted at the same level. However, having said that, then we might say, well, then can a woman drink during pregnancy if she has all the good things going on for her? Not really. Alcohol will still have a detrimental impact, maybe not at that severe level, but still will impair the structures of the brain of the unborn baby. So in that sense, because we have no way of controlling all of these variables, like who drinks alcohol and what is going on in their lives. So that's why we cannot control any of these variables, right? And then the other piece is when a mother drinks during pregnancy. Well, it has an impact at every different trimester. However, it has some significant impact on some trimesters where the brain development is at its peak. So if a mother drinks more heavily during the first trimester, then this is when the facial features of the baby are being formed. So if there is alcohol exposure on that first trimester, then we will see more facial features that probably a lot of you are familiar with, which I will also show in the slides. If a mother drinks more heavily during the second trimester, then we will see more like impact on the organs, the internal organs, like the heart, the vision, the eyes, like the hearing, and then some of the internal organs. We will see something on, the liver and things like that. So if there is exposure on the third trimester, then this is exactly when we see a heavy development of the brain. This is exactly when the brain development is at its peak. So then it interferes with the migration of the cells for the brain structures. And at that point, this is when a mother really needs to focus on their good nutrition, getting lots of protein so that the brain development can happen really well. However, alcohol really interferes with this. And as a result of that, we will see a lot of impact on neurocognitive functioning of the baby later when they're born. So another factor is the quantity of the alcohol consumption. There could be one mom who drinks maybe once in a while. There could be another mom who has substance use issues, and they might be drinking throughout the whole pregnancy, like chronic consumption. And there could be another mom who would engage in binge drinking, right? Not drinking for a while and then drinking lots and lots, like in a couple days. So among all of these things, of course, the two are very harmful and detrimental. One is binge drinking, because it really floods the unborn baby's brain with alcohol, and the unborn baby's brain is unable to metabolize that alcohol, unlike the adult brain. So when adults drink alcohol, alcohol leaves the brain, starts leaving the brain within a couple of hours, and then it gets metabolized, it goes down to the body, and then it gets flushed out. However, the unborn baby's brain is unable to do that, so it sits there, and then the brain absorbs it like a sponge, and then it starts kind of like impacting the brain structures, unfortunately. So in that sense, flooding the brain with a lot of alcohol through binge drinking is also very harmful. Of course, another form of drinking, which is heavy consumption throughout the whole pregnancy, is also very detrimental. However, it is very hard to know when certain parts of the brain are going to be developed at one point for every woman. We do know that there is a timeline for when the organs and when the brain structures develop, but it also differs from every woman to woman. Just like for any child, right? One child walks at 12 months, another walks at 18 months. And do we know beforehand which child will walk at 12 months, which child will walk at 18 months? Not really, right? It's the same thing for women. We have no way of knowing which women will be able to metabolize that, and when their baby's brain is developing at that moment. So alcohol will interfere with that development at any time. Therefore, because we don't know this information, we have none of that information, we can't do research, of course, with pregnant women telling them, oh, this group drinks and this group does not drink. That's not ethical, and that's never going to happen. We only know this from animal studies, and animal studies do show that alcohol consumption during any time of pregnancy is detrimental to the unborn baby's brain. So as a result, what we conclude at this point in terms of research is that there is no safe amount of alcohol during pregnancy, and no timing in that sense too. No safe time also to consume during pregnancy. So in this slide, you can see, and as you can guess, these are two brains of infants who have passed away at 6 weeks of age, unfortunately. And then the one on my left passed away from SIDS. And then the one on my right, the smaller one, is a brain of a child with FASD who passed away from the complications that they experienced after birth due to chronic consumption of alcohol in utero. So I want you to kind of like have a look and kind of like think, what are some of the differences, in these two brains, right? So as we can see, the one on my left who was not exposed to alcohol is more intact. And the first thing probably that you all noticed is the size, right? So the size definitely shrinks due to alcohol. And because of that, what that means is smaller brain size leads to what we call microcephaly, which is the smaller circumference of the brain. That means that the structures in the brain are smaller. And when the structures in the brain are smaller, there is less space in the brain, which equates and which translates to less of the functions of the brain when they are born. So that's one thing. And then the other thing that you probably are able to see right away is the lack of curves, right, in the brain, which we call all of these, connections. So the one on the right who has been exposed to alcohol has a more smooth, especially on the right hemisphere of the baby's brain, it's more smoothed out, right? It doesn't have the curves and the angles that it's supposed to have. So this is the gray matter and then the white matter there. So we want a brain with all of the curves, because all of the curves are the connections in the brain that kind of like make all the structures. And then if you can see in the middle part, there is a section that connects the two parts of the brain. That part of the brain is also kind of like some parts are missing. So either we see things like thinning of some of the structures, the surface is smoothed out, the brain size is smaller, and then also what we see is that some of the structures are, when the baby is born, some of the structures in the brain have some parts of it, but not all parts of them. So, of course, what this does not mean that not all children with FASD will have intellectual impairment. But a lot of them or some of them will do, or some of them will have what we call borderline intellectual functioning. So it means that this will translate to cognitive impairments and other impairments that we will talk about. So that's why we call it invisible disability, because again, when people think about alcohol, they don't think about like the impact, the direct impact that it would have on the unborn baby's brain, unfortunately. So if we think about, okay, then what are some of the structures in the brain that are impacted with alcohol? First of all, alcohol impacts the mid part of the brain. That is one fact that was found out. And then the middle part of the brain is, first of all, this area, which is we call the frontal lobe of the brain. This is responsible for attention, behavioral regulation, planning, organization, and all of those very important factors, right? And then this part of the brain, which is the temporal lobe, this area, the hippocampus, as you can see, is responsible for memory formation. That's why children with FASD have significant memory-related issues. And then we have this part at the back of our brain called cerebellum. The reason why people who are intoxicated when we all, drink alcohol, for those of you who consume a little bit alcohol, even if it's a little bit more, what happens? People lose their balance, right? That's why the police ask them to walk like, in a line just to see what their balance is like. Because alcohol makes a direct hit on the cerebellum, which is the back part of our brain that controls our balance and motor coordination. So, what does it mean for a kid with FASD? It means that a child with FASD will have coordination issues, motor issues, issues with balance and being clumsy, and so forth. So that's what it translates to. And then another area that gets impacted is called hypothalamus. Hypothalamus is again in the middle part of the brain that helps us with what we call self-regulation. The reason why when we wake up in the morning, we can tell if it's like morning or night, or the fact that we can say, I'm hungry or I'm thirsty right now, is due to that structure. So when that structure gets a hit, what happens is that they have sensory related issues. They may not know when they are hungry. They might eat more than they need. They might not be able to regulate their behaviors, which means that when they get dysregulated, maybe that sensory things around them is too much for them and they have hard time settling down. Because we can more or less, we can settle ourselves down. We can say, okay, what is going on with me? I'm tired. Let me take a nap. All right, what is going on with me? I think I'm hungry. Let me eat something. So we can get these sensory cues in our bodies really well, whereas our children with FASD struggle more with that part. So not being able to get those cues, then what they feel is dysregulation, and then they get frustrated, and they might not even know that they're frustrated because they're unable to get those cues from their body. And it's all due to the impact of alcohol damage on the hypothalamus area. It's not because they are being, willfully rejecting to do these things. The brain does not order that. The brain does not say that, hey, you are tired, please sit down. Or the brain doesn't tell them that, oh, you are overwhelmed right now, let's just rest a bit. So they cannot connect those cues, which, in turn makes them, feel just agitated, have those mood swings up and down, and all of those things that we see more behaviorally. But at the back, lots of things are happening in their brain, which we cannot really see. That's why, again, we call this invisible disability. And then the last thing that it gets impacted, which is really important, is what we call corpus callosum. So corpus callosum is a structure right in the middle of the brain that connects the right and the left hemisphere together. And what it does is it helps us to communicate. The two brains need to communicate with one another. So what I see on this side gets projected on this side. What I hear on this ear gets projected on this part of my brain. So this corpus callosum kind of connects all the information and helps us transfer that information so we can make sense of what people are saying and what we are seeing in our world. So when the corpus callosum gets impacted, sometimes some children with FASD are born without the corpus callosum, or the corpus callosum is very thinned out, or it's very like flat. So what it means is that when they hear something, when they get an instruction, when they learn information, it does not cross over easily. I'm not saying totally, but it takes more time. So they have a slower processing speed, which means that the way that process information is much slower than their counterparts. They do understand it, but they might need more repetition. They might need to hear it one more time, maybe in a more simple way. And as a result of that, they might seem more confused. And therefore, they might seem more frustrated when you even give them a simple instruction that you are certain that they know what they're supposed to do. And you might get all like frustrated, like, I know you get this. I know you know this. Like, how come you're not like doing this? And then we might then think that they're doing this in a willful way, right? Or the teachers sometimes say that to me, like, I know they can do this. Why did I not do that? Well, it takes a little bit of time for the information to travel to the other side, for them to process information. So these are some of the areas that get really impacted with alcohol. So when we think about the facial features, some of the common facial features are, as I mentioned before, there is a smaller head, which we call microcephaly. And then the eyes right in here, they have these epicanthal folds. It's almost like folded a bit. And then the eye openings are small. They're usually more round. And then the face is pretty flat. We wouldn't see a whole lot of cheekbones, for example. It's all flatted out to the side because of the impact of alcohol. And then what we see is also a low nasal bridge. So if you all do this, this part is very much smoothed out for them. It goes like whoop, kind of like almost down. And we always have a little bit something here we might have. And then the next thing is what we call the smooth philtrum. If you all do this, hold it from the bottom of your nose down here. What do you all feel? Like there is a little bit of a groove here, right? Kind of like going up a bit. I mean, yes, we all have different, facial features with, race and ethnicity and so forth, but this part has a little bit part going up. So in our children with FAS, as you can see in the picture, it's all smoothed out like this part is smoothed out. Okay, that's again with the impact of alcohol as the facial features are formed in the first trimester. Alcohol kind of like interferes with the migration of the cells and everything is smoothed out to the side a little bit. Then we see an underdeveloped jaw. We wouldn't see a jaw structure. It's all kind of like, again, like very flat there. Okay. And then the last piece is the very thin lip, upper lip. And we see this across ethnicity and race. So the upper lip is like very much smoothed out again, like almost to the side. And that part is kind of like always very, very thin. Now I'll show you some of the pictures, and here you can see some children from all 4 different races and ethnicities. And as you can see the round eyes, right? The epicanthal folds, and then the very flat face, no jaw, structure there. And then you see all the philtrum? This part is kind of smoothed out with all of them. And you see all the very thin upper lips there. So these are kind of like all across different races and ethnicities, we can see the impact. So it's not bound to one race or ethnicity. We can see it all across the impact. All right, so before I move on to this next section where I'll be talking about the red flags, I wanted to see if there are any questions, because I saw some chat, but I think it's more for announcements and other things. But because we are also a smaller group, I wanted to see if anybody wants to ask any questions so far about the parts that I've already talked about. And I'll also get questions at the end too, but just making sure as we are on the topic. Right. Let me look at it again, but I guess not at this point. So I will, yeah.
Is there anything that is out there that will help with the development of the frontal lobe, or is this something natural?
You mean like after they're born?
Yes, medication.
Yeah, unfortunately, we do not have a medication. We want the babies to be, as you all know, like to be full term, right? With the full weight as much as possible. So those are all things that we want them to stay inside and not be exposed to cigarettes, alcohol, and drugs. And then the mom to have a good, nutrition and prenatal care. And that is after that, we can hope for the best because there are also genetic factors that we cannot control, right? So after they're born, though, what I'd like to say is that screening and after that, referral for a diagnostic evaluation is really, really important because the first 2 years of an infant's life and then the toddler's life is very important for the frontal lobe development. I just read a new research yesterday that 18 months, the frontal lobe activities like that behavioral inhibition, like holding yourself not to do something, harmful, right? Not touching the stove and all of those things. It develops right at that 18 months of age. So if we can catch this early, and then these children can start early interventions services, right? Early on, then actually some of those frontal lobe actions, some of the frontal lobe activities do develop. And that is that, developmental time when it would be wonderful if we can have that impact right at that time versus when they're 10, right? By the time they're 10, it is a bit late, and we miss that window of opportunity when the brain is still very, we call plastic, right? Malleable, like kind of like can change. The brain, I mean, we were created, this brain is like a wonderful thing, and it is very plastic at any time, I would say. Even people who get stroke and things like that, they do recover, but the first 2 years is a tremendous time of change. It's almost that post, after they're born, those 2 years is the time when there is so much rapid brain development. So really, if we can enroll them to early intervention services, even if we have a little bit of a suspicion, we may not have the full diagnosis for later on, but some of the slides I think is really important to maybe share with those that you work as well, because then we can say, I'm suspecting FASD. I'm not really sure, but I think they would need early intervention services, and they would benefit from that. Maybe they will just end up having ADHD, but early intervention services would not really hurt, any child, definitely. And it will be so helpful if the child later gets on diagnosed with FASD. So that is probably the best thing that we can do. And that's why we're so keen on screening, early identification, referral for diagnostic services, and starting these services pretty early on. Yeah, I think that's a great question. And let me see.
Dr. Ergun, we have
Mhm.
another question in the chat. The question
Yeah.
is from Dr. Dodard Peterson. She wants
Mhm.
to know if there's any effects from male sperm, if
Yes.
the male has, been consuming alcohol during that time,
Mhm.
and does that have an effect?
Yes, definitely. And we get this question a lot. So in terms of the male sperm, so if they, consumed alcohol, and I think it is more not just for that time of like when there was intercourse and things like that, but in general, the quality of the male sperm is very impactful. So, and alcohol also decreases the quality of the male sperm. And then in general, it leads to more mutations in the genes of the baby in general. So in that sense, when we think about it, of course, if the male, sperm has been impacted, but the mother doesn't drink during pregnancy, then we will not have FASD. So it is more the mother's drinking during pregnancy to cause a full, blown FASD there. However, what the alcohol does is it impacts that quality of the sperm. And then also, if there is things like substance use issues and so forth, then of course, genetically, those do pass on, of course, to the fetus. So that is kind of like the impact. But more importantly, what research indicates is that if the partner, right, has substance use issues or has drinks a lot and so forth, that impacts the environment of the home. And then as a result of that, the mother is more also likely to drink. And that we see that has a much more bigger impact on whether a pregnant mother will use alcohol or not. So if they have a supportive partner who is also more protective and just kind of like says like, okay, maybe we should refrain from, using alcohol together and we're going to have a baby and so forth, then that leads to actually better outcomes. So all in all, what we can conclude is that, yes, it is not good for the quality of the sperm. However, if the mother doesn't drink, if the father drinks, through the sperm, it will not just lead to FASD. So we can still prevent FASD with the mother not drinking during a pregnancy. So that's not a causative, like a causal factor there, but it has impact.
And Dr. Peterson also makes this a comment that that's
Yeah.
not discussed very much in terms of
I
the impact.
totally agree, Dr. Peterson, that it does not, and we're really just focusing on, on the mother part. And I think the reason is more because that we can prevent, the FASD part. However, with all my clinical experiences too, that if a mother has that, supportive, partner, and that environment does not involve alcohol and drugs and so forth, and even after birth, right? Because 70% of the children with FASD are taken away from their biological parents. And the number one reason is continued use of alcohol and drugs in the home environment, and then due to neglect and that environment not being conducive for that child, which has a direct impact of how the partner is supporting the family. And if the partner does not have the substance use issues and so forth, then the family can also stay intact and they could raise their children and so forth. So it kind of like has a very cumulative effect at the end. And I agree with you that this is something that needs to be studied more and mentioned more. And I think in our in the FASD steering committee, and Karen, I saw you there too, but we have a lot of emphasis on the impact of males and fathers in FASD. And I think that's something that we need to keep, mentioning and working on. All right, so I will go on with the next part of the presentation. So in terms of now that we have a good idea about, how FASD occurs, what are some of the factors, variables, and so forth, now what are some of the red flags that we can see throughout different age ranges and then the course of this neurodevelopmental disorder. So the signs and symptoms can be a bit harder to identify in infants. And then the reason is that it kind of overlaps with other neurodevelopmental disorders pretty much. So what are some of the other neurodevelopmental disorders that it overlaps? Well, autism, for example, or a general, developmental delay due to prematurity and other things, right? However, some of the things that we will see is emotional withdrawal, being less responsive to parents. When the parents kind of try to engage with the infant, then they don't respond as much. And then, things like that eye contact, just that harmony with the parent and so forth. And they also have speech delays, such as things like cooing, babbling. We would see those to be a little bit later on. They have a lot of poor sleeping patterns. So we would see a lot of things like colic, not have a good sleeping pattern, not being able to, be breastfed or take the bottle, a lot of like poor suckling issues and so forth, which ultimately can lead to failure to thrive. So if you have any babies that are failure to thrive, I would definitely say that just dig a little bit into whether there has been some prenatal alcohol exposure. Because again, the impact of alcohol on the unborn baby's brain, they usually are also born with low birth weight or prematurely. And after that, because of the difficulties with that suckling and oral motor skills, and then if you remember, I talked about hypothalamus, right? Hypothalamus is all about knowing when you're hungry and all that. All of those issues start, the sleep issues, the eating issues start like very early on. So those would be our red flags for the infancy.
Doctor, at the time of birth, just like with drug-exposed infants, do they go through withdrawals?
That's a wonderful question. So they do not. They do not. So drugs have that more of that specific that withdrawal, the high pitched cry and the trembling and all of those very rough things that we see for drug exposure, we do not see in alcohol exposure. So in that sense, when they're born, we cannot identify that they have been exposed to alcohol. As rough as it is, for infants who are born with drugs in their system, it is identified right at birth, and it can be treated, and it has then less impact on the child's development. For alcohol, it still gets metabolized, but the way it gets metabolized, it just almost like has that damage into the structures, but it doesn't have this withdrawal impact on the body of the baby. So therefore, we cannot identify it at birth, unfortunately, and we still don't have a good way for that. They have tried to look at the meconium, but none of it has been really a good marker. They're still working on ways to identify it, and if we can, I think that would be wonderful at some point, but we are not there yet in terms of research. So therefore, we cannot identify it. And then if we don't know all of these red flags, it kind of like gets almost misdiagnosed. The misdiagnosis rate is 70%. That is huge, and that is very unfortunate. And the age of diagnosis is around 9.8 years. Almost by 10, then that's when we diagnose them. And for autism, it's around 4 to 5. For ADHD, it's around 6. I mean, we catch them pretty well. We miss FASD. We think that most kids with FASD only have very severe ADHD. That's all we can, figure out at this point. If they don't have the facial features, it is an invisible disability. And that's why we're struggling in this area more than other neurodevelopmental disorders. It's a great question. The red flags in toddlerhood and preschool years. So now we start seeing something a little bit different. So this is the part I think we can all have our kind of like red flag part up. So preschool years are when they start learning their colors, their numbers, their shapes, right? So this is the time there is rapid learning. That's the time I mentioned. That 0 to 3 is just like huge time for learning everything. So at this point, kids with FASD, they do learn. We don't say that they don't learn, but they learn, but then they forget. And then they learn, and then they forget. So as Dr. Chasnoff always gives, who's a renowned scholar and a clinician and a doctor in this area, always gives this example, which I love, is it's almost like those Christmas lights. When you take your Christmas lights the next year, you want to make sure that you can use some of those lights. And then when you start wrapping and then you light it up and you go like, ooh, some of it it lights up and the others don't, right? So a child with the FASD, their brain, he compared it to just like that. Sometimes it lights up, sometimes it won't. And it is due to what I mentioned, that corpus callosum. The information sometimes passes through, those neurons light up, and sometimes they don't. So then a preschool teacher might say, oh, Jana, I taught you these things. You know your colors. Why don't you tell me? And say like, I don't know, I don't remember. And then another day they might remember that. So that whole memory issue starting really early on those early years in preschool is a very important piece that we need to catch on. So we need to look at if a child is able to learn in a steady pace and they can build on to the next information. Okay, so that is what we need to look at. Another one is lack of fear. Our little ones with FASD, they can just jump off from the roof. They can leave the home. They wouldn't fear, because usually a 2-year-old would go like, should I leave? Then where's my mom? Where's my dad? Things like that. They don't really think about that. And the reason why is the frontal lobe. The frontal lobe is the part that connects the cause and effect. Oh, if I do this, then I'll be on my own, or nobody can help me, or I'll be hurt, right? That's that connection with, if I touch the stove, whoops, okay, I cried the last time I touched the stove. So the next time I'm not going to put my hand on the hot stove, right? So that is called associative learning. So we learn through experiences, and then that gets encoded in our frontal lobe. But because of the impact and damage on the frontal lobe, that part does not have that memory of it. So they keep doing the same type of harmful behavior over and over again, right? That's what we call perseveration, doing the same thing over and over again. And we might think like, why would they do that? I mean, they already had a bad experience about it, and you would think they wouldn't do it, but it is that connection is unstable. Let's call it. It's just like that internet connection sometimes when it says like unstable. So it's more like that. So we can see that very severe hyperactivity in an attention right at that age of, around 1, 2, that is not developmentally appropriate, right? And they don't benefit from the typical parenting practices. Timeout wouldn't work. They would cry even more, or doing consequences does not really work. So they can kind of struggle more with that. And then they could have that excessive pain tolerance that they might not come to you and say like, I'm hurt sometimes, because again, they have some like hyposensitivity, hypersensitivity. At one point, they could be hypersensitive, like very sensitive. At another time, they would have that lack of sensation for certain things. So that's why also they would also need some kind of like occupational therapy. And those are the things that I was mentioning about early intervention services. So they would need things like speech and language therapy, occupational therapy, sometimes physical therapy, depending on their needs. So in the toddlerhood preschool years, we can start differentiating them from other children with other neurodevelopmental disorders, like autism and so forth. So this is not our typical ADHD. It's more severe, and it does not respond to typical parental disciplining practices. So if you have that, I would say let's have our red flags up there. Okay. In childhood, now they start school. So they have a very short attention span. They cannot sit much. They have hard time with fine and gross motor skills. Self-regulation issues become very prominent, and they have really hard time learning to tell time and use money. So what they struggle with is understanding the concept of time. Okay, we say, oh, I will for it, 7 or 8-year-old, we could say, in 5 minutes, we're gonna go to the next class. So you need to go to the next class. So have your things ready. So they can engage in something, and that 5 minutes does not make any sense to them. So it's like that concept of time is really, really hard. Same thing with money, learning how to count money, understanding those coins. Those are very, very difficult concepts for children with FASD. So all of these lead to problems with adaptive functioning, like day-to-day living. So a child with FASD could have an average IQ. This is here. When someone has average IQ, we expect that their daily living skills is consistent with their IQ, right? But a child with FASD can have a normal, typical average IQ, but their day-to-day living skills or adaptive skills are always going to be lower than that. So which means it cannot come up to here as easily. They would always need that supervision. They would always need that extra help. Although we might say, why? Because they have typical regular IQ. They don't have ID. They don't have cognitive issues as much. So why they struggle with that? It is that hypothalamus that we talked about. They have hard time regulating, and the frontal lobe, the impact of the frontal lobe, because a lot of our day-to-day functions is regulated by our frontal lobe. The fact that you all woke up today on time saying, I have a training to go to today, is because of our frontal lobe. We can do it, right? We can get up, make ourselves get up and get ready and show up to places, and that's due to our frontal lobe. But if the frontal lobe gets impacted, that's something that people cannot do. It's the same for when people have a traumatic brain injury or they get shot in the frontal lobe of that area. They have hard time doing their day-to-day functioning, their activities. It is the same thing if it's acquired, but this one is due to alcohol impact at birth. When they become adolescents, we see more problems in the social area. Our children with FASD are more naive and gullible, and they are more easy to take advantage of socially. They want to be with their peers. So this is when we can differentiate them from autism. Our autistic children don't like to mingle as much. They don't approach other children as much, but our children with FASD, they are very friendly. They could be, again, most, I would say. They could be friendly. They could have a little bit anxiety approaching, but other than that, they like to please others. They want to do things with the other people. However, at the same time, they are very easy to take advantage of. So during these adolescent years, if other peers have figured that out, they can put our teens into situations where they can get involvement with the legal system. So they may be persuaded to approach another teen, engage in sexual promiscuity. They can be persuaded easily to steal something. They could be persuaded to engage in things that they're not supposed to do. So in that sense, teaching safety skills, starting early on in the elementary years, right? Teaching things about like sexual development and their bodies, what is safe touch to others and to themselves, and then not going with strangers because they can be pretty gullible and then go with strangers, engage with them and so forth. So these are some things that we really need to take care of when they're in elementary school. So by the time they come to the teen years where they're already, just because they're teens, they will have issues with teenage, years, that they want to be more independent and so forth, then that's the time that it'll be really hard to regulate them. So the more we invest and do and all of those interventions earlier on in the elementary years, then we will have less of issues during the teenage years. So because of all of these things, if they realize that they're different from their peers, then they could have more things like self-esteem issues. Depression can sink in during the teenage years, thinking that they're more different than their counterparts. So those are some of the things that we need to take care of. And if they need to see a psychologist, a counselor, for some of these extra mental health issues, those are what we call secondary issues that will be on top of the primary issues that they are also experiencing. So these are some of the secondary issues that we see. Depression, anxiety, they could drop out of school. 70% of them, unfortunately, drop out of school because the system or the teachers, not just the teachers, but in general, we all as the system have a hard time understanding their experiences. So they might not do well in school, so they might decide to drop out. They could engage with the legal system. Again, 70% of them have some kind of legal involvement. Also, because of their behavioral dysregulation, they are more prone to use drugs and alcohol, which means it's because more of their impulsivity and their difficulties with understanding cause and effect. Well, if I use this right now, this is what's going to happen. If they already have the compromised frontal lobe, and frontal lobe really is our CEO, right? That tells us, no, don't do this. Yes, do this. Because of that, then they have really hard time in what we call judgment and decision making. So those are things that I think, Robert, you asked that regarding what can we teach. Early on, we have to teach them things like problem solving skills, which I will talk about later today. And then that what we should know about, like in terms of good planning, problem solving skills, so that they can make some better decisions. And then as they become adults, managing money, employment, and then those are the things that become a lot more difficult during those years. So seeing I have a half an hour, I know I talk a lot. I want to talk about the interventions too. So I think I mentioned a little bit, so I'm going to go through some of these a little bit fast so that I have time to talk about interventions, which is also very important. And you'll have the slides too to go through, but I will just say a couple things about each slide, although I have tons of good information in there. So 70% of children with FASD get diagnosed with ADHD. That's why we would see ADHD first, and then we try to see like, oh, if it's also something more than ADHD. So what we know is that they don't respond as well to ADHD medication, unfortunately, but 70% of them do have ADHD. If you have a child who has severe ADHD, that is, happens early on, diagnosed, and then they don't respond well to medication, I would say that have your red flags up. So that is really a marker, okay? A lot of them do have learning disabilities. They might have an intact IQ, but they still have learning disabilities, especially in things like reading comprehension, written expression, like writing essays, understanding what they read. They read well, actually, in terms of sounding out and so forth. They learn to read, but the whole like getting the gist of an essay or the gist of what they read, and extracting that more abstract. They have a hard time with abstraction. The more concrete it is, the better for them to learn. Okay. And they could also have a math learning disability because of things with time, money, quantitative things are really hard for our children with FASD. So if you see things like math learning disability and so forth, and issues with time, I would say have your red flags up again. We already talked about social skills, so they could be pretty gullible, and because of that, we need to work on social skills training. Early on, I would say I would start preschool and elementary school years, so by the time they're teens, they have developed some good social skills to be able to lead their life. And adaptive skills, as I said, are always kind of lower, so they would need more supervision and more help to lead their day-to-day life. And I would say life skills training and working on those as they continue is a really, really important thing in the treatment. All right, so children with FASD then have neurocognitive deficits, and that due to the structures being impacted, right? And we talked about all of these things. Then they have self-regulation difficulties. We also talked about that. And then these are just some examples of what those are. And they have adaptive functioning deficits. So this is that triangle that we call. So if you're trying to screen a child, I would always say, look at those neurocognitive issues, adaptive issues, and self-regulation issues. And when we put all of those three together, that triangle, then we can say, we can start to form an opinion. And some of your clients and those that you work with or you care for, you might say that maybe they might have FASD. Okay. And of course, those social skills. So wanted to see if we have questions on these parts for the red flags before and the symptoms before I move on to our basic interventions section.
I don't have a question, Dr. Ergen, but I would like to say I could listen to you speak on FASD all day long. This is an excellent presentation. Thank you so much.
Oh, thank you so much. That makes my day. Thank you, and glad that it's helpful. Mm-hmm.
Yeah, she's on point. Very excellent information. You're talking about diagnosis and the different stages. Who or what where in the child's life has the ability to provide the diagnosis? Is it a pediatrician, the school system? Where is that diagnosis to take place when there are these red flags?
Definitely. That's a wonderful question. And I have some presentations on just the diagnosis part on our website too, and the Ohio Mass website as well. So here is in a nutshell. So once you see the red flags, and at the end of the presentation, I provided as resources. On the resources page, there is a free screening that can be utilized to screen, and anyone can really use that. And then after that, if you have your, suspicions, then there are at this point two working interdisciplinary clinics. But one is in Toledo, one is in Cleveland at the Rainbow Babies. And then there, once you refer, then this is the team. So we have to have one medical doctor who would be either a developmental pediatrician, could be a geneticist, that looks at the facial features. They will measure the facial features because it's really important. And then they will do the whole height and weight and the head circumference. They will do those measurements. That's by a doctor, one. The second one is either clinical psychologist or pediatric neuropsychologist has to do neuropsychological testing to look at things like learning, memory, IQ, executive functioning skills, adaptive skills, and so forth, and the behaviors, right? And then that information gets put together in that interdisciplinary team, and then they together decide on under which of that FASD umbrella that the child can qualify. So a child can be diagnosed with what we call FAS, which is fetal alcohol syndrome, which is the most severe form of it, where the mother drank throughout the whole pregnancy, when they have facial features, growth issues, and neurocognitive issues. then they could have something called partial FASD, where they have some of the facial features. They don't have the growth issues, but they have neurocognitive issues too. And then the third one, and the most prominent, is what we call ARND, alcohol-related neurodevelopmental disorders, which is the least severe form of FASD, where most of the time the IQ is intact. So that's why we don't see them being identified before, because they have average IQ, right? But they have all of these neurocognitive issues that I was just talking about. So that one is pretty hard to just diagnose, by just interacting. They need to be, going through all of these evaluations, and this team makes the diagnosis, and after that, they can start their interventions. So that's how that goes. And I'll look at some of the other questions. Read the meds. If it's okay, I'll read. My 11-year-old grandson was diagnosed a year ago. So was also ID'd as gifted, born perfectly healthy, but refused to take the meds. Not sure if there's another route to administer. We're struggling right to severe behavioral problems, which parallel the ODD, like oppositional defiant, since his parents returned to their home. Earlier this year, desperate right now, called the crisis hotline last evening due to behaviors in Ohio Rise, and the care coordination will be there afternoon. So for the ADHD, yeah. I can talk a whole lot about that. I'm happy to stay after, because I want to make sure we can get through the intervention piece. But I'm happy to talk about the medication and why it doesn't work in that route. But there are some other things, and I'll have one slide about the medication piece, and then what will actually work. Maybe when we talk about the interventions, then maybe it'll give you also a better understanding of what actually would work better, even more than medications. But there are things for the ODD part of it. But obviously they have to take the medication. That's a whole nother thing for the medication management part. All right. So I will go on and talk about some of the basic interventions. Also, I do, I've done trainings for whole just on the PACT curriculum to teach some of the organizations as to how to handle the behaviors and the full interventions. But here I'm just going to do a summary. So because this is a brain-based issue, then all of us, psychologists, therapists, caregivers, teachers, we have to be the external brain for our children with FASD. So what does that mean? Because we use our frontal lobe to guide our lives. But if the frontal lobe has been impacted, which means that our children with FASD are not able to use their frontal lobe as efficiently as we do. Therefore, we need to be almost their external guide to help them out. So one first thing to understand is change our understanding and thinking that this is a neurological impairment. This is not willful or bad or intentionally done behavior that they do. Some of that ODD behavior, refusing to take meds, refusing to do homework, and all of those things. So because they are impulsive, they have disorganization, memory issues, emotional regulation issues, and so forth, what they would benefit most from is a very structured, consistent environment where they keep learning and growing, and then where they do not get exposed to sensory, cognitive, or emotional overload. So our children with FASD, it's not a population of children where we can overwhelm with things. So amount of information needs to be smaller in chunks till they digest it, okay? The environment, we cannot change the environment too much. We need to keep it simple, structure. We need to keep a daily routine and a structure. And this calm environment where they also have one-to-one attention is what benefits them the most, okay? So the interventions will be the most impactful if they get a good amount of stimulation, right? So not too much. Structured and predictable, that's the word. Predictability is what benefits our children with FASD the most. They should know what's going on next. Well, we can say life is not that way, right? Anything can happen. Once we know, we should also inform them, saying like, hey, today you don't have speech today because the the speech your therapist called and they're sick, and we need to inform them as early as we can, and then because then they could get dysregulated because that's what the brain is expecting. Okay. We need to review the daily routines and discuss about their feelings for changes in the routine, saying like, I know you're used to going to Miss Miss Sally, every Wednesday, but we don't have that. So what can we do that on that Wednesday so that, you don't feel like, frustrated and so forth. So in that sense, we need to work on how to kind of like predict some of those, and then how to work through transition times, especially at home or at school. So what would the interventions would look like? Breaking the task into manageable steps. So complete one thing at a time, then have mastery through lots of practice and practice and practice. Remember the brain with the two lobes not communicating all the time. So smaller information, don't overload, and then lots of practice till it gets ingrained into memory. So we cannot move on to the next thing until they have learned this basic piece. We have to give praise for each completion. Children with FASD benefit ton. They don't benefit from punishment. They don't benefit from negative reinforcement. They benefit only from positive reinforcement. And they don't even benefit from consequences. That's why we might say that it works differently. So we also need to help them identify when they're becoming overwhelmed and how to ask for help. Because a lot of the times when they get frustrated, they could freeze. They could freeze and then they would shut down, or they would have a meltdown and they would become more aggressive. So putting their cues together, what is your trigger? What is your cue to let you know that you're getting frustrated? So in one of our interventions, we have this very nice thing that's called, how does your engine run? So it gives that analogy of sometimes we run low, like low on gas, right? Sometimes we have good amount of gas. Sometimes we have way too much gas, which means way too much energy. So we make that concept of self-regulation something that is more tangible, right? So we do this pedometer where we kind of say, how does your engine run? And then we can have them identify and say like, I think your engine is running a little bit high right now. What can we do so we can just settle down? So really what we're doing here is we teaching them self-regulation skills, which is something that they need very, very much. So when they get unsettled, when they get dysregulated, then we encourage them to go to a quiet, calm area. And this is not timeout. This is what we call cool down area, right? So this is not a punishment. This is just for their brain to settle and then for them to kind of like get back to themselves, right? Because they cannot do it themselves. So this is how we become the external brain to help them out. And while we do that, we need to use charts with words and pictures because guess what? If we give them instructions, they might not remember due to their memory issues. So we need to give the instruction verbally. They need to see it on the chart, and we might need to guide them also sometimes physically so that they get some of those things done. We also need to teach them how to ask for help. They might get frozen and shut down, and we don't want them. We want them to be independent and being able to know what their needs are. So kind of saying like, I see that your engine is running really low right now. It looks like you don't know what to do next. What do you need to do? Like, okay, what can you do? Well, I can ask for help. So then who can you ask help from? So we kind of like walk them through some of these stages because that's also frontal lobe. Frontal lobe is going through step-by-step sequencing, and sequencing is very hard for them. So we teach them sequencing skills. First, you need to do this. Then what do you do next? We walk them through each of them in that patient way, okay? So for school, some of the things, for example, these are again more similar things, but they would need frequent breaks. We need to set goals for time to remain on task because they could be off task pretty easily due to their ADHD, right? And at school, they also need to have that cool down area. And the teachers really need to have repeat directions for them, and they need to use brief directions. So they cannot take 3 types of information in their mind. For example, if we say, I'd like you to take your folder and then go put it in the cubby, and after that, when you come back, please help your friend to do X, Y, and Z. No. So we need to do, please collect everything and put them in the cubby. Okay, go. Did you do it? Okay, great job. All right, the next thing is, can you bring this type of folder for this homework and bring it to your desk? Okay, come and do it. Done. Okay, then the next thing. So, and this is due to their working memory issues. Working memory is getting the information, holding it in your head, and doing something with it. They have severe working memory difficulties. So that means they cannot hold the information in their head without seeing it written down or without seeing it visually. So any verbal instruction, we need to connect with something visual so that they can actually hold it in their head. Okay. So those would be some of the things to do for school. So for school, we also need to minimize distraction because they can get distracted very easily. To having them seated up front, reducing the amount of independent work. They cannot do a huge task or a huge project. So we start with the first part of the project and we say, like, you are done with the first part. What is the next thing that you need to do for this project? What is the second part? So then you do this part. For the second part, what are the steps that you need to do? So they have hard time seeing the whole big picture and going through the sequences by themselves. So we need to be their external brain for that part. In terms of some of the memory strategies, because they struggle with memory, right? We've talked about that greatly. So we have to break the information into smaller segments. We need to provide mnemonics, some kind of like external memory aids, like lists, notebooks, stickies and computers or timers, and saying like, you're going to work on this for 5 minutes or 10 minutes, and then you can go on to this next thing. And then monitoring is making sure that they understand what they need to do. This is so simple intervention, but just like this, you've given some instruction to a child with FASD, and after that, all we need to do is like, can you repeat for me what is the ask? Like what is the task to do? Because you would know that sometimes they didn't understand it, but they could pretend that they got it. And after that, you go like, why didn't you do it? And at the end, what we figure out is that they actually didn't comprehend all of the things that they need to do, right? So we need to check for comprehension. Then we need to help the child to become actively involved in the activity. One big intervention for kids with FASD is we need to give them an experiential experience, which is they need to do something with their hands and with their whole body, and then they need to get up and do something. And it is not just sitting and listening that would make them kind of like learn and remember. So for that, they need to be actively involved. You go and, when you're learning about the circumference of a thing, take out your shoe and then just draw around it. So they need to break down the abstract concept into something concrete, and they need to be involved in something. So have them get up and do a lot of things and rehearse and rehearse and rehearse the sequences. These are the best, memory strategies that we can utilize. In general, supervision is the key, as some of you have already are doing a lot of that. Keeping the environment organized, they don't benefit from chaos because the brain that is compromised needs a more stable, calm, and organized environment. The brain is already disorganized. So we cannot put them in an environment where the environment is also organized. So disorganized brain and the environment is disorganized, it doesn't go well. So more organized environment, even if we can do it for our families that we're working with, they might have many children, they could be single parent households. At least we can say, have them a corner at home, even if they don't have their own room or anything. Have them a corner, just a corner where just like a little table and it's something where they can sit, have their own stuff. Maybe have them go through and do their clothes for the week, right? All folded, those little cubbies that you can do in a dollar store. You can just put all of their clothes and what they have to do, like their, things for the whole week. and they could just grab it instead of trying to search for it throughout a disorganized home. If you remember, I talked about problem solving, right? And decision making. And judgment, problem solving, decision making are not their strong suit here. So then we need to teach them the whole basics of problem solving. So we go through what is the problem, and we only do this after they're calm, after they're calmed down. We don't do this during a meltdown, a tantrum, or when they're dysregulated. Once everything is done and finished, then we go and say, so what was the problem that we experienced today? What are your options? What were the things? So this is all about brainstorming. They don't do well with brainstorming, so we need to help them. Say like, okay, you say one thing, then I'll say another thing. Okay, well, you could have done X, Y, and Z. Now you find one. So we help them kind of generate some solutions. Then we can say, so in this thing, what could be the best one to use? You pick one. And then they pick it, we apply the solution, and we say, do you think it's helpful in this situation? And we can even do this with social stories and cards, like create a social problem, okay? And then use cards because it's visual. And then we say, what should this child do in this situation? And then we work and work and work on problem solving. The better they get at problem solving, then it will be much more easier for them to evaluate their own social situations and then give better decisions when they engage in those situations. When we give directions to our children with FASD, first let's give the directive. Then we give a lot of time for completion. We should be patient here because of, remember that processing speed, that they process things a little bit more slowly. So let's give them time, okay? And they cannot be rushed. We already talked about that. Then let's give a second directive with the reminder to comply, or we can say, remember, this is our consequence. And then we remind that. If they do it, we give them praise. Great choice. Great job for picking up your toys. If they don't, we provide the consequence for the negative choice, right? And then later on, then we can say like, okay, remember you had some other choices that you could have done. Let's maybe go through them again and see which one you would have, you could have chosen for next time. But when we discipline, these are some really important things. They already have a negative self-concept about themselves. So we don't want to reinforce that. So we need to increase our attention to only positive behaviors. We have to pick our battles here. We can ignore some negative behaviors unless they are harmful to themselves or others. Of course, then we need to intervene so they're safe, right? Or others are safe around them. But if it's a smaller thing, we can just pick our battles. We have to provide frequent praise to promote that self-confidence and competence. This is really important. And we have to avoid punitive consequences and provide more natural consequences, right? So natural consequences are our biggest help there. We need to frame timeout as a cool down. We don't want to leave them in a room. No, that's not it. They need to have their cool down area. We can sit with them. We don't need to interact much, but we can say, I'm here for you until you get your engine just right, until you settle down. So this gives them a message that they're not alone when they're struggling, that we are with them and we will not leave them alone. I think that's different definitely than from timeout, where we kind of say attention away from you, timeout, you think about what you've done. That's not what we do. And then once they calm down, then we talk. But if they're not calmed down, that's not the time to engage, okay? And we have to administer the consequences in small doses because our children with FASD don't handle something like you lost your iPad or your computer for a week. That is way too long, and they will not be able to connect the dots that it's that week, and they will have a bigger meltdown. So we can say, for the next couple hours, we won't have your iPad, and that's your consequence. But once you do X, Y, and Z, you can gain it again. So we try to work on positive reinforcement again, all about that positive reinforcement. All right. So when they have a meltdown, that's the time that they don't understand and process information. That's when all the brain almost shuts down, okay? So then we have to avoid those power struggles and provide options where they have soothing and comfort. Think about the brain is compromised and we need this brain to settle down, okay? So we have to designate that quiet, calm area, both at home or we could even have like this little quiet down box in the car, even saying like that's your calm down box. We could have one little thing in the car, one at home, one in the school. And once they display dysregulated or sensory seeking behaviors, we could gently guide them saying, I think it's time for you to calm down in your cool down area, and I'll be there with you to help. So this is an area that we could have bean bags, soft pillows, low lighting, some good music, squeeze toys, water, some chewy things to kind of help them slow down. And then that is not a punishment. That is almost saying that's where you need to recollect yourself and rebuild yourself, like getting into this more organized behaviors, right? So that's where we want to do. And then finally, for educational support, many would require an IEP or Section 504. They could qualify under other health impairment, OHI, and they would have accommodations at school. And we're hoping that a lot of the times what happens is that the caregivers are more knowledgeable on FASD than the school system. That's what I've seen. So if your child has been evaluated outside through an evaluation, please bring that report to the school and they can utilize it, because the schools will not be able to do a neuropsych eval. They could do a cognitive and an achievement test, but they will not be able to diagnose FASD. So you need that outside evaluation, and then you bring the information to the school and take it to the IEP and be the advocate for your children to have all of those interventions and accommodations at school that they need. For the medical consultation, I think one of you had that question. So when we go to the psychiatrist, I always talk with the caregivers and the parents and say that these are the 3 behaviors that our children with FASD struggle with that would require medication. One is behavioral issues, which would be things like ODD, oppositional defiant, right? Aggression, throwing things, and not complying with directions and things like that. Another one is dysregulation. This one is totally like having that meltdown. Is just like, oh, I don't know what to do, mixed with anxiety, and they're just like they're sensory seeking, they cannot settle down. So that's dysregulation. It's not the saying like, no, I won't do it, but you visibly see that they're struggling and they're so dysregulated. And then the third one is hyperactivity, which we all know. It's just jumping up and down and just, the whole this super activity. So once you talk to the psychiatrist, then I would like you to kind of like put them in order and say like, which one is troubling you the most as a caregiver, right? So then the doctor can also decide and say like, okay, right now we need to start maybe with a little bit of something like Strattera, maybe not the stimulant, but the Strattera, for example, for the hyperactivity. And then I could give something for dysregulation. So they will also make a decision which one is the most important right now to address. But then if you go, when you do your psychiatric consultation, if you think ahead of time and then maybe give some examples for all these 3 areas, then the psychiatrist's job is also going to be a little bit easier to decide about the best medication for your child. And of course, while we take care of our children, we need self-care, because it's a 24/7 job. So we need to look at our own practices as to, how do I take care of myself? What are some of the barriers to my own self-care? Do I have respite? Do I really understand what it is? And if we had more time, then I have that self-care exercise, the wheel. I'm sure you've seen that before. We shouldn't really think about self-care as like taking a walk or eating well and so forth. We need to look at all walks of life. Psychologically, how am I taking care of myself? Physically, how am I taking care of myself? Am I putting my career to the side because of my role as a parent or a caregiver? What about my own hopes and ideals and goals for myself? So we need to make sure that we take care of ourselves in all of those domains. And then the last piece is, our children with FASD have diminished self-concept because of all of these difficulties that they go through. They have a lot of strengths. But most of the time we're focused so much on their primary issues and secondary issues, and we may not sometimes see beyond that FASD piece, like who they are, and that's something that needs to be fostered, right? So we need to give more verbal praise than we criticize. We need to give more positive messages, because most of the time what they hear is more negative messages from teachers, parents, caregivers, doctors even. So that is a really important piece that we really need to keep working on. And then the last piece as we hit the timeline is case management. Our children with FASD have tons of needs. So we might need to take them to the doctor regularly. That's very important because they could have medical complications. We need to take them to the psychiatrist just to get checked out. We need to make sure that, we kind of like look at all of their needs. So it would be great to work with a caseworker or a social worker who can kind of like manage all of those, either for your clients or for yourselves as well. So as professionals, what can we do? We need to understand what FASD is. We need to advocate. We need to refer. We need to screen. We need to work with the other multidisciplinary team to provide information of all the things that we see and observe. And I would say just keep advocate, and disseminate this information. You learn here, you share with others the next day. Okay, and here I put a link to the Ohio MAS webpage where you put FASD in the search, and you will have tons of wonderful resources that the FASD steering committee has put together. We have a lot of those that would be really helpful. A lot of training seminars, toolkits that they were developed, peer support group. Tons of things there. And then I put the links to the diagnostic centers that you can refer to. And I put a link to the screening tool. For this one, you need to go into the middle of the document. It's a huge document that it's also very helpful. But you need to go to the middle of the document to find the screener there as well. Well, thank you so much for listening. And let me, look at some of the information here. There is some emails, and then Karen, thank you so much for putting your information there. And then there's things for certificate. But if you have other questions at the end, I would love to answer and stay more for even more questions.
Well, I really want to thank you, Dr. Ergen. As you can see in the chat, people are very appreciative of this information, and it's very complex and there are a lot of moving parts to it. And the time frame that we gave you, you did a wonderful job in doing that. I think what we would like to do at a later date is if you were willing to come back and do more in depth on the intervention process, that last half of your presentation, I think would be very beneficial to our caregivers because I think a lot of them are realizing that some of these symptoms, they've seen them if they've not been diagnosed, and they're seeing them. So, and even if they have been, maybe they just haven't been educated on their own ability to intervene. So we will talk, offline about that and see what we can do. Let's see, there's
Yep, I think Peggy-Lynn has a question, so I'm happy to answer. And yes, I'm happy to continue to consult together, and we can talk about that.
Go ahead,
right.
Ms. Faulkner.
Yeah.
All right, thank you. Good afternoon to everyone. I don't so much as have a question, but I'd like to say, where were you 14 years ago? I'm sitting here listening to everything that you're saying. And my grandson was misdiagnosed. He was only diagnosed for ADHD.
Right.
And I tell you the things that I went through in school. He's 18 now. He just got diagnosed with oppositional dysregulated disorder 3 years ago, when it probably should have been diagnosed when he was 4 years old.
Exactly.
Okay. So, right, the medication, it worked partly, but
Yeah.
I didn't understand why it didn't take care of everything else that was going on, his defiance and all of that. And it's because the teachers don't really know how to deal with it.
Exactly.
I had a chart on the kitchen wall for him for when you get up in the morning, you make your bed, you go to the bathroom, you brush your teeth, you do this, you come have breakfast, you go get dressed, you get your book bag, you
For the
walk
external brain, yes.
right. And it was there for him to see. You come home, you change your clothes, you get your homework, you get a snack. But I had to have it on the wall for him to follow day by day.
You figured it out. Yeah.
Oh, but it was still a struggle. So thank you so much for wanting to know about what causes these things in these children with the alcohol, okay?
Yes.
That so that they, yes, you need to come back. More people need to hear about this. This was awesome. I enjoyed you immensely, and I will leave now. I'm complete. I'm
Okay.
finished. Somebody else will have a turn.
Thank
Thank
you
you.
so much for sharing your lived experience too. Those are always the most also the valuable for us, and just getting that confirmation that, we need to keep working and advocating and screening and referring. So thank you again for being on board and, getting this information in this training. The more we can learn and then disseminate, now you're going to be in the position to disseminate to others. That's very
Yes.
important. So let's not undermine all of your roles to kind of, just continuing in this journey all together. We're all in this together. So thank you so much.
You're
Thank
welcome.
you.
Thank you.
Thank you,
I
Ms.
want to
Farmer,
make
for
sure.
your-
Oh,
I'm sorry.
go ahead. Well, I
I-
just want to make sure I make the announcement for the gift card for the caregiver who's going to receive the gift card. Mr. Dimitrakis, you will be receiving a $50 gift card, and I will contact you after the meeting to get your information in order for that to happen. So thank
Wow,
you for attending, and thank
you so
all of the
much.
caregivers. You're welcome. And all the caregivers and people from agencies for attending. Go ahead, Ms. Dewberry.
Oh, I was going to say a thank you to Dr. Ergon for a presentation. I'm hopeful that the attendees, from what I've heard, have found it to be very informative, as well as I. We want to thank everyone for joining us today, and we hope that you'll be able to join us on August the 19th as we begin to prepare for Advocacy Day. It's very important. At the beginning of the workshop today, we announced how we would like everyone to be involved with that as we prepare to reach out to our state senators and state representatives to make them aware of the importance of kinship care, and hope that everyone will be able to join us then. And please invite another caregiver if you know of someone caring for someone. At this point, Barb, did you have anything to add?
If anyone needs a attendance certificate of attendance, please email me, and we will get one sent out to you with all the information for today's attendance. Thank you, and thanks everybody for coming and participating, and thank you, Dr. Ergun, for an excellent presentation.
Indeed.
Thank you. And finally, I'd like to thank Karen Kimbrough, the FASD Steering Committee Chair, for connecting me with your organization. So just wanted to acknowledge her as well there.
Well, we look forward to having you back as soon as possible.
Alrighty. Thank you so much. Take care.
Goodbye. Take care.
Thank you, everyone.
Goodbye.